We're going to talk about the DRE method, his primary method used to evaluate individuals with an injury. So it says use the ROM method when the impairment is not caused by an injury or when an individual's condition is not well represented by a DRE category. The ROM method is now also used to evaluate individuals with an injury at more than one level or at the same spinal region. All right, so what does all that mean? So in the beginning, impairments were primarily based by evaluating the patient's range of motion. That's how up until about the 4th edition. Then they brought in this thing called DRE, diagnostic related estimates. And it really made, to be honest with you, it made it much, much easier given impairment ratings. It's like, they're just tables and you kind of point at them. Does the patient qualify for some of these factors? And if they did in the table, then you pick that number. So it made impairment rating much, much easier. But we do want to be aware of both. We're going to cover some of the basics of range of motion because you do want to be aware, okay, this is DRE and this is ROM, range of motion. What are the differences? Okay. Now, it does say, the guide says here that we're going to use the DRE method for injuries. So that's the general consensus. If it's an injury and it's one area of involvement, we're going to use the DRE table. And you're going to see it's relatively easy. Now, does it say you cannot use the range of motion method? No, it does not say it. So it says the range of motion method should be used if statutory mandated in a particular jurisdiction. So again, you just need to be aware from your state. Now, this is the AMA guides, so it's a physician function. If you're a physician, you can give the guides and it's your opinion, okay? And they're guides, not rules. So, but you do want to be aware in your state if there are any modifications or restrictions or add-ons. Maybe there's something, and that's why I say you need to check with your, usually who really knows is the Trial Lawyers Association. They usually, because they're dealing with impairments all the time, or the workers' compensation. But just be aware there is a difference between a disability and the workers' compensation. So they could have restrictions with workers' compensation that don't apply to personal injury at all. So just be aware of that. Those are two totally different animals. But usually the personal injury uses the information of workers' compensation. But do not assume they are one and the same with regulations and regulatory agencies. They are not. Okay. Okay, so it says spinal condition is only rated when it is stable, unlikely to change within the next year, regardless of treatment. What's that called? MMI, maximum medical improvement. Okay. And we cover that in detail. So you definitely shouldn't. That MMI is based on the science of the 3 phases of healing. So it all starts with knowing the basics of the science of the 3 phases of healing. That takes us to MMI. And then from there, we have to know subjective, hybrid, and objective evidence to help support the impairment. Okay, so let's go into this here. The principles of assessment says the evaluation should include a comprehensive and accurate medical history to review all patient medical records. Okay, current symptoms and their relationship to daily activities. Okay, a thorough physical examination and all the findings of relevant laboratory, radiologic, electrodiagnostic, ancillary tests is useful. That the rater include in the report a description of how the impairment was calculated. Now, one thing you want to be aware of is you only do want to use what's called medically accepted diagnostics. Again, you do not want to give an impairment rating and included some test that is not medically accepted, because now if you have an attorney who's worth half his salt, he's going to take that and just ruin your credibility. So one of the things we always say is never use diagnostics that are medically accepted. And I cover those definitions separately. What's the definition of medically accepted? What are the common things that chiropractors use that are not medically accepted? Well, there's 3 big ones that chiropractors use. Neurocoulometer, that's not medically accepted. Thermography is not medically accepted. Surface EMG is not medically accepted. Now, I'm not talking about dynamic surface EMG like the ROM. That is medically accepted. I'm talking about static surface EMG. That is not medically accepted. And then you go, what's the definition of medically accepted? Well, the general definition, there's a few categories to it, but bottom line is it peer reviewed? Has it been shown in peer reviews? Number one. Number two, is it commonly used in hospitals and medical facilities? That's the definition of medically accepted. So, not to get into the weeds with neurocalorimeters and thermography and surface EMG, but I highly recommend you do not use those and don't use anything that's not medically accepted. Or if you have any kind of decent attorney, he's going to take that lack of credibility and just kind of spread it around and kind of make you look bad all the way around. So, interpretation of symptoms and sign. So the history, primarily based on the individual's own statement. Medical history should consider the information of others. So you definitely want to consider all the other information. So if you need to get other information, if that person has seen other doctors, other exams or tests, you need to access them. You need to get them so you can take a look at them and see how they apply, or do they apply relative to this impairment rating. So if information from the individual is inconsistent with what is known about the medical condition, circumstance, or written records, the physician should report and comment on the inconsistencies. So it says the history must, the chief complaint and the quality, severity, anatomic location, frequency, duration, symptoms, including pain, numbness, paresthesia, weakness. We know that. That's basic information. And then it says a way in which the condition interferes with activities. So it says document exacerbating and all alleviating factors and the way in which the condition interferes with daily activities. The physician should elicit the history of when and how the condition started, precipitating factors, the relationship to any previous problem. So we know that. So again, we're talking about how this problem causes pain or restrictions with activities of daily living. And of course, it's so important that we go in great detail on how to document activities of daily living with each of the three ranges of motion: active overpressure joint motion, which plane of motion, and the quantification thereof, because it's that important. Okay, so that takes us response to treatment. The results of special studies that have been performed should be described, and available x-rays or other imaging studies. Okay, we know that. And then a physician should focus on spine-related physical findings such as range of motion, reflexes, muscle strength, atrophy, sensory deficits, root tension signs, gait, and the need for assisted devices. Now, in the low-impact soft tissue spinal injury, are we going to see very many assisted devices at MMI? No. Could we possibly see some gait inclusion? Maybe, but not too likely. Root tension signs, not too much. Sensory deficits, not too much. Atrophy, not really. Muscle strength, you very well could if you do the test right, and I explain how that's done. Reflexes, not typically. Range of motion, definitely, but remember, there's three ranges of motion, not one. And most of the positive findings are in overpressure and joint motion, and they're typically not in active range of motion. So we do have to be aware of the three. We got to measure, we got to quantify each of those three. That's where the majority of the problems are with low impact soft tissue spinal injuries.